So, identifying exactly when ours started is a little bit hard to say, because it kind of was a slow buildup. So as far as how many there are in the U.S., it's hard to know an exact number. I would say maybe just a handful. And I think on the West Coast, so if we think about a NephroNICU as providing neonatal dialysis, there's just, I believe, 2 centers on the West Coast and maybe west of the Rockies. We like to think of a NephroNICU as a bit more all-encompassing beyond just neonatal dialysis, and it really takes care of a myriad of kidney issues that arise in the newborn period or prenatally. So it goes beyond end-stage renal disease and encompasses other things like acute kidney injury, hypertension, and other anomalies that require intervention or special support after birth. So, Dr. Sutherland and I were talking about this. It really dates back to about 2013 as far as how we kind of pushed ourselves into providing care for very small babies. We had a preterm infant born who needed dialysis, and that was really our kind of proof of concept that we could do this, that we could really work together, adapt our dialysis technical aspects to make it work. And we would take care of maybe one or 2 patients a year for a little while. And then when the renal anhydramnios fetal therapy trial launched, that really, I think, catapulted us into doing a lot more of these babies. And so Dr. Sutherland and I were thinking back to, really it was sort of like the spring, summer and fall of 2020, where we really started taking care of a greater number of babies with end-stage renal disease. That really prompted us to think about how we should formalize this program, get a multidisciplinary team on board to provide the best care.
That's a great question. One, you can sort of take kidney disease and split it into 2 major groups. One is the group of diseases that are sort of congenitally acquired, and the other is the group of diseases that show up after the patient is born. And so if you're thinking about congenitally acquired kidney disease, one of the most common diagnoses is something called congenital anomalies of the kidney and urinary tract. It's abbreviated CAKUT. And that happens in probably 1 in 1,000 patients. And that condition, or that group of conditions, ranges from very mild to very severe. So not all of those patients are going to need dialysis. Not all those patients are going to need very intensive nephrology care. That number is going to be lower than that 1 in 1,000. And then if you think about diseases that are acquired after birth, something like hypertension or acute kidney injury, acute kidney injury is very common. We probably see it in somewhere between 20 and 30% of our neonates. Now that also has a spectrum of severity. It can be relatively mild and self-resolving, or it can be severe enough that you would need dialysis or at times even transplant. And so, of that 20 to 30% of patients who develop acute kidney injury, maybe 4%, 5% actually go on to need dialysis, which is probably, around 1% of patients admitted to the NICU. If we're just focused on dialysis, historically, we have done dialysis in all children using adult devices. These are the same devices that are being used in the intensive care units at the adult hospital next door. And obviously, when you're using a machine built for a 70-kilo person, the farther you go from that weight, the harder it is. And so in the NICU, where even the largest patients are 3 and 4 kilos, you face all sorts of challenges. And as the patients get smaller, those challenges become more pronounced. And I think one of the biggest challenges that we faced is access. And so when you're doing dialysis, you need to have some sort of dialysis catheter or some sort of dialysis line that gives you access to the bloodstream so that you can actually do the dialysis technique. And all of the adult devices require very specific catheters, which are challenging to put in large neonates and physically impossible to put in the smallest neonates. And so we had a handful of patients that were either too small to receive these catheters, or were unable to for other reasons. And that's where this aquapheresis device was initially used. It's a device that was originally developed to remove fluid in adult patients, and we sort of modified it for use in the neonates. And the biggest difference is that it can be run using smaller catheters or smaller lines. And so the access issue that we were facing was sort of solved. There are still a lot of challenges about using that device in neonates. It's not meant to do dialysis, but we're able to modify it slightly so that it can provide clearance of molecules, can clean the blood in addition to removing fluid. We're now using a different device in addition, which is actually it's a device that was designed to do dialysis in neonates. So it's a similarly sized device, but it doesn't require any modification. You can just use it to provide dialysis therapy. So a lot of the decisions that we've made and a lot of the technical aspects have revolve around getting access and trying to provide the therapy in very small patients.
Yeah, I think as we embarked on this journey together between neonatology and pediatric nephrology, it became clear that we needed to assemble a bigger team that all had a sort of a shared mental model of how to care for these babies. Some of these babies are born prematurely, and with that, there's extra considerations for nutrition, for example. And so our dietitians have become real experts in understanding the special nutritional needs of these babies, that acknowledges the fact that they're on dialysis, that they sometimes have, we have to think about different formulations that address the fact that a baby is on dialysis and at risk for having certain imbalances in their electrolytes, and how to minimize those. As Dr. Sutherland mentioned, vascular access is really critical when we're providing hemodialysis clearance for these babies, both in the short term, like how can we physically make that happen, but also having an eye towards the long term, because these are many of these babies are going to go on and need an eventual kidney transplant. And Dr. Wong, our medical director of dialysis, had many years ago done an improvement project called Save Our Veins to really respect and appreciate the vascular access challenges that these babies who grow into children, who grow into young adults, experience over the course of their lifetime. So those have been some really key collaborators. We've had to, assemble a really expert rehabilitation team. These babies are in our unit for many months sometimes, so that they can, we need to help them not only survive, but thrive, and help them achieve their developmental milestones. They're often, undergoing dialysis for many hours a day. So we need to make sure that they get opportunities for mobility, and bonding time with their families. And so our infant development specialists, our physical therapists, our occupational therapists are all really key members of our team. And then finally, as we get towards having these patients go home where they're going to be on dialysis until they grow bigger, that's where our amazing transplant team comes into play as well. And they're involved from the beginning.
I think Dr. Davis does a great job talking about how all the different teams and all the different team members work side by side, providing day-to-day care. I think one of the areas where I see this most strikingly is in the original evaluation process for a lot of these patients. Many of these patients are seen by neonatology, by nephrology, by dialysis, by transplant, by obstetrics, even prior to birth. And so getting all the expertise in one room really helps us make decisions. So when the patient is born, we know exactly what the plan is. It also helps with counseling. I can certainly let a family know what dialysis is going to look like day to day. I can talk to them about the transplant roadmap, but I don't have a great understanding of what it's like to be a preterm patient or what it's like to be in the NICU for months. And so having the different teams together, helping the family understand what the path looks like, not just over the first month, but over the next couple of years, I think is really valuable.
Yeah, and I'll just add on to that. We've got a robust fetal program that also integrates many of these disciplines, and I think another important one is our social workers. Again, because these families have a real journey that they embark on, sometimes starting the prenatal period, and seeing them through those first few months where we're supporting them with dialysis until they're ready and stable to go home. Our social workers are a really important part of the team in supporting these families. Sure. I think it depends on when, at what stage the calls come in. Sometimes we have families reach out after getting a prenatal diagnosis. It's really incredible what social media can do to connect families. We've had conversations with families. They've sometimes come from out of state to deliver with us. But it's also just understanding your local environment. What resources and expertise do you have, and is that team something that can support a newborn? And then even within the scope of a newborn infant, it's, some centers are able to support a baby who's fully grown, but may not have the technical expertise locally to support a preterm baby. So it's just understanding your local resources. And if you don't have that, then maybe look elsewhere. And then, we like to entertain and offer hope to families who might not have it locally.
I encourage the physicians to reach out to a center who has this expertise, whether it's our center or a different center, as early as possible. I think it really helps determine whether the patient can be managed locally or whether the patient really should be transferred. And I think it's important to note that when we get these calls, we don't transfer every single patient, and a lot of the patients stay locally. Sometimes it's just a one-time consultation. Sometimes it's sort of an ongoing consultation. And some of these things can be managed from afar and don't require being physically here. But having that conversation early really helps us identify the patients who would benefit from being here at our center or a similar center close by. I think there are a handful of things that I think are really exciting right now in adults and older patients. We're starting to see some medications be developed that can sort of alter the arc of chronic kidney disease, maybe can slow progression, can help kidneys last a little bit longer. In pediatric patients, one of the things that's really exciting is the commercial availability of biomarkers of kidney injury. When we're talking about kidney function, there are a handful of lab tests that will follow that will help us determine if the kidney is functioning well or functioning poorly. We don't really have the ability to identify injury. We assume that there's injury if there's dysfunction, but there are some new commercially available tests that are going to help us identify injury, which will be great from a prognostic standpoint, great from an intervention standpoint. The other thing that's really exciting, it's actually something that's happening here in our program as well, is we're starting to do sequential stem cell kidney transplants. And this is only in a subset of diseases. We're doing it in some very uncommon diseases in patients who already need a stem cell transplant and need a kidney transplant, but it has incredible ramifications for transplantation in general. And so this is something that a couple of the physicians here are pioneering, and I think it's really exciting for these patients long term.
I'll just add to Dr. Sutherland's comments. I think what I've seen really just in the last couple of years is, as he mentioned, we've had, historically maybe had to adapt an adult device to meet the needs of a neonate. But as manufacturers are starting to appreciate that we can support these babies survive, and that this is a market, that they are willing to get into this space and develop technologies, and really kind of move technology forward so that we can provide the best care for babies.